Before we get going, if we're going to talk about methadone, right, it's helpful to understand where we're starting from. And last year, more than 110,000 people in the US died of a drug overdose. Most of these overdose deaths involved opioids, especially illicitly manufactured fentanyl. Methadone, for folks who aren't already familiar, is a gold standard medication for opioid use disorder. It is one of the most effective tools that we have to combat this crisis, right? So methadone is a long-acting opioid agonist. This means that it curbs withdrawals and cravings and allows people to better get on with their lives, right? Reclaim their life, um, meet work and family obligations, have healthier relationships with themselves and their loved ones. The medication has been shown to improve treatment retention compared to non-medication treatment. It reduces people's likelihood of using illicit opioids by about fourfold, and it cuts their overdose risk by as much as 60 to 80%. People on methadone are also less likely to contract or transmit infectious diseases like HIV and hepatitis C, and they tend to be healthier overall than their counterparts who are on in non-medication treatment or are not in recovery at all. And these things are not only beneficial to the individuals who are taking methadone, right, but also to their friends, their loved ones, their family members, and also to our communities as a whole and taxpayer wallets. So it's really something that has the potential to have a huge benefit across the board. Methadone is, however, heavily regulated in the US, unlike any other prescription drugs are. The only way to access it for opioid use disorder is through a system of opioid treatment programs, or OTPs, which you might hear folks talk about today. These require many patients to come to the clinic as many as 6 days a week in order to take their medication in person. Keep in mind, there's only about 2,000 OTPs in the entire country, which means that a lot of people have to travel more than an hour each way to reach the clinic. A limited number of take-home doses, commonly referred to as take-homes, are available to patients at various stages of recovery, but this access tends to be tenuous. It can be dependent not only on their ability to get to the OTP on a regular basis, but other factors like passing urine screenings, and other things that can make it really difficult for people to stay in treatment. And then losing that access has deleterious effects. So the Modernizing Opioid Treatment Access Act, commonly referred to as MOTA, is a bipartisan federal bill that would improve access to methadone by allowing addiction specialists, doctors, and psychiatrists to prescribe it and pharmacists to dispense to people with opioid use disorder. This wouldn't get rid of OTPs, but it would create another system through which folks could access the medication, adding more than 3,000 potential prescribers and 61,000 possible points of access through pharmacies. One of the concerns and why we're here today that we hear from opponents or people on the fence or people who are just learning about methadone, one of the things people worry about is that since methadone is technically an opioid, the change could increase the risk for diversion, which is loosely defined as the informal selling or sharing of prescribed methadone with someone else. So today, we are chatting with a panel of experts, including physicians, scholars, and people with lived experience with methadone, about the realities of methadone access and diversion. I will briefly introduce our panelists, and then we will get to it. So we have Erin Ferguson, who's on the leadership team of the National Survivors Union, a group of directly impacted methadone and buprenorphine patients and people who use drugs. He is the Texas Regional Outreach Manager for Community Medical Services, a national provider of methadone and buprenorphine. Erin also produces a podcast about drugs and the people who use them called Narcotica, and a show about methadone patients titled Naturally Non-Compliant. We have Paul Jodrey, an assistant professor in the Division of General Internal Medicine at the University of Pittsburgh School of Medicine. He provides primary care, addiction medicine, and harm reduction services in both outpatient and community settings. His research focuses on identifying factors impacting addiction treatment access and outcomes across urban and rural communities, and developing, evaluating, and scaling interventions tailored to community needs to improve the health of people who use drugs. Noah Kravchik is an assistant professor in the Department of Population Health at NYU Grossman School of Medicine and a member of the Center for Opioid Epidemiology and Policy. Her research focuses on studying ways to address barriers to evidence-based treatment for opioid use disorder at the individual, program, and policy levels. And finally, we have Samuela Manages, who will be probably joining us on and off. She was kind enough to fit this panel into her schedule today, even though she's traveling. So hopefully we'll get to hear from her as well. She's a medical director for an opioid treatment program in Presque Isle, Maine. It's the only methadone clinic in the county. She graduated from Massachusetts General Hospital Harvard Medical School and Addiction Medicine Fellowship. Her goal is to create a comprehensive addiction care service in her rural community in order to integrate addiction treatment and primary care. And she provides treatment with both methadone and buprenorphine and advocates for methadone flexibility and access in order to stop the rise in overdoses. So thank you all. And now we get to the point where I get to stop talking and get to start listening more. So I want to start with Paul. And Paul, would you give us a little bit of context as to why people are so worried about methadone diversion? Like what are the potential harms to individuals, to communities, et cetera?
Yeah, thank you. And just let me just start by saying thank you, Arshree, for putting together this event, and grateful for the invitation and the chance to talk about this really important topic. So, just to be just kind of really direct, methadone is an opioid, just like morphine or oxycodone or hydromorphone, which are examples of opioids that are available in pharmacies. And like other opioids, methadone, if taken, ingested outside of set, safety parameters, is a sedating medication. And if taken, above recommended amounts, it can lead to respiratory depression and then overdose and even death. And of course, that's a very serious potential consequence of methadone use. And so just to start kind of just simply and conceptually, like other opioids, methadone does require oversight, and we need to be careful about how it's administered and how we provide supports for people who are on methadone to eliminate and minimize the risk for that outcome. And also, it's important to acknowledge that, like other opioids, if they're prescribed and taken home, we want to make sure that there are safety measures to prevent accidental exposure. If someone's prescribed oxycodone, they bring it home. We want to make sure that it's in a tamper-resistant bottle. We want to make sure it's difficult for kids to access it. And that's because methadone, like other opioids, can cause this sedation and respiratory depression. So this is a very important issue, and we do need to be careful and deliberate about how we monitor methadone.
Yeah, thank you so much for that. So, I mean, I do think this is a really important point, Paul, right? Like I think nobody is talking about this issue and downplaying the potential risks associated with methadone. What they're doing is trying to put it in context, right? And really recognizing that access is still a life-saving piece of this. Erin, let's kind of shift a little bit to some personal experience. And then also, I know you've got a good sense of the context, right? Like, as someone who's both taken methadone and worked extensively with methadone patients, can you talk a little about how the medication affects you and others who take it?
Sure, and thank you, as Paul has said, for opening up an opportunity for a discussion about this topic. I think it is something that needs to be discussed out in the open, and that the arguments on both sides need to be appraised. I think that's how we figure out the solution to big problems like the one that we're facing. And so thank you for the time and opportunity to do that, and also to share my own perspective. So I come to my views on methadone and diversion and methadone regulation from a number of different angles. I've been a patient, a person who quite a bit owes my life to access to methadone. I've been a provider, I've managed clinics, I've been a counselor for hundreds of patients, and I've worked in outreach advocating for access to methadone and methadone funding. And I represent a group of thousands of methadone patients across the country and people who use drugs who are part of a movement toward reform that we believe is largely the result of some of the regulatory changes that has caused a shift in the conversation about how methadone is delivered. And we're grateful for the responsiveness to that. Many of our lives depend on it. I survived using drugs, and methadone included, after escaping being born and raised in a religious sex trafficking cult called the Children of God. I wound up living on the streets as a child. And, there are documentaries and books written about the cult. But suffice it to say that I had a lot to overcome growing up, and drugs helped me to do that. They also almost killed me on a number of occasions. And if it wasn't for the times that I had access to methadone that was being snuck out of the clinics, I probably wouldn't be alive. I also served in the military for a number of years and would not have had access to methadone when I was forward deployed unless it was diverted, because the military and the VA does not provide methadone. Something to consider when it comes to people who use drugs and the aspect of methadone access that relates to privilege is the fact that a person experiencing homelessness is just not going to be able to access methadone in the way that it's currently delivered. So I was living on the streets a lot, and daily dosing just was never going to happen for me. And now, as fentanyl is progressing and becoming more and more available, and methadone treatment is becoming less attractive, much of that has to do with the way that diversion has been dealt with and the punitive measures that have been implemented with methadone's delivery. And so we've come to the point where folks are more willing to risk dying than they are to do what's necessary to seek treatment. And as Stacy mentioned at the beginning here, we're seeing a stadium full of people that's dying every year, and that's simply unacceptable. It's bad for the economy, it's bad for our culture, and all boats sink when we lose this many of our fellow citizens. So, I'm here to speak on behalf of people who are directly impacted. I hope that some of the ideas that come out get people thinking. I'm not a spokesperson or representative for the company that I work for that provides methadone. There's a diversity of views about how diversion should be dealt with and how methadone should be delivered. And there's also a diversity of views among the methadone activist community. But there are a number of things that we do converge and agree upon, and I'm going to outline some of those when I speak later. But suffice it to say that our lives depend on this reform, and that most of the problem that we currently are facing has to do with how we have allowed fear to dictate our decisions. And diversion is a prime example of this. So I'm hoping that with our discussion today, we can right size our diversion concerns in the context of the potential benefits of delivering methadone, and that we can have a conversation about why it is that risk is the most salient thing when we are talking about people who use drugs. Why is that the main focus of the conversation? There are some places where we really do agree, right? The current system's ineffective. SAMHSA has made these regulatory changes and is calling for a cultural shift at the clinics. And if there's one thing we can definitely converge on, is that there is a need for change when it comes to the way that methadone is being delivered. And we know that we simply cannot solve a problem from the same level of consciousness that created it. We have to think bigger. And the best way for us to do that is to follow science. And the best science starts from the direct lived experience of people who use drugs, who are trying to access methadone. It starts there. It doesn't end there, but it starts there, and it's responsive to that. So science can help us to tackle these big social problems, but it asks us to check our biases at the door. And this goes back to the question about risk.
Yeah.
On the topic of bias, is it possible that a century or more of punitive mindsets about people who use drugs could be affecting the way we think about diversion? And if that's the case, science can probably show us the way, but this is going to ask us to prefer rationality over emotion. So I'm here to help with that discussion today, and I really appreciate everyone's time. I'm looking forward to my co-panelists outlining an appraisal of the evidence, and happy to be part of the discussion.
Yeah, thanks, Aaron. And I think, you really touched on something that I'm excited to ask both Noah and Paul about as we go forward, but it's that how the current system keeps folks from accessing methadone through formal channels, right? And that it makes it really not only difficult but often dehumanizing for people when they try to. But I want to kind of, before we jump into that conversation about why diversion happens, I want to ask you, Noah, since you're one of the people who's been really involved in a lot of this research and really understands, you have a great handle on it, I think more than most of us. COVID offered an almost natural experiment for us, right? And the opportunity to see, when COVID happened, we saw some changes in the way that methadone was regulated, and where they allowed more take-home doses for people. What did we know about, based on that, based on data from before? What do we know about methadone diversion in the US today? And what don't we know?
Yeah, thank you. And I really appreciate this conversation. And really took this was a great motivator to kind of look into the science. I'm familiar with some of it, but really tried to do a deep dive to really get a sense of, like you said, what we know and what we don't know. And I'm just going to share one slide. I'm an epidemiologist, so I'm a data nerd, and I do think that sometimes graphics can be really helpful in just giving a sense. I just want to put in context kind of what we're talking about here when we're talking about weighing methadone risks versus benefits. And just to remind people, methadone diversion and methadone risks, they're not occurring in a vacuum. As everybody's mentioned, they're occurring in this backdrop of other overdose deaths, mostly among people who use opioids that are not getting access to medications like methadone. So just want to point people to these numbers, which here you'll see a graph of overdose deaths, where on the left side, these are overdose deaths that occurred before COVID-19, and on the right hand, deaths that occurred in the year after March of 2020 when COVID-19 hit and the regulations around methadone changed. And what you'll see very starkly is this difference between the orange bars, which are non-methadone involved overdose deaths, and the blue bars, the very small blue bars, which are the methadone involved overdose deaths. So just two takeaways to just frame some of the evidence around this is, first of all, methadone deaths compared to other opioid and other overdose deaths are just a really tiny part of the issue that we're dealing with. There's a lot more people who could benefit from methadone and are not receiving it, as we can really see starkly in these orange bars. The other thing is that we see a really tiny uptake in methadone overdoses, about 1,000 additional methadone overdoses in the year following COVID compared to before COVID, versus an additional almost 24,000 overdose deaths that did not involve methadone, changing from the year before to after COVID. So I think this just highlights, there was not a huge increase in methadone overdoses, which is the biggest concern around methadone in general, including methadone diversion, which Paul mentioned, right? There's a concerning risk about people using it that aren't supposed to. It's a risky medication. You don't want it to get into the hands of people who don't need it or might be unsafe around it. But here you see that even with much more flexible regulations after the COVID-19 changes were implemented, these fears didn't really come to appear in the data. We did not see a huge increase in overdose deaths. But we did see this increasing and persistent need for making treatments more accessible. So just putting that as context, I want to be really honest about what we know and don't know in terms of kind of the methadone landscape. It's really hard to measure methadone diversion. There's no database that measures methadone diversion. It's an illegal activity. It's really hard to distinguish between methadone that's for pain medications versus methadone that's for opioid use disorder when it comes to an overdose or a seizure, a police seizure, any kind of other data that we can get about methadone diversion. So I just want to start with that to say, like, people have very strong opinions about what kind of will change methadone diversion or what would increase risk or decrease risk. And the truth is it's really hard to study. So I want to just caveat it with that. And if somebody tells you they know the answer to what policy will solve or worsen diversion, that, it's not really, we don't really know the perfect answer to that. But we do know a few things from the research. And so the first thing just to mention around COVID, like I said, we did not see increases in overdose deaths, significant increases compared to other overdoses. And we also did not see an increase in diversion. Some studies that have tried to look at this saw really kind of some mixed findings in terms of adherence to methadone, in terms of looking at whether patients, stopped using their methadone as well with more take homes. And we didn't see anything like that consistently. We also didn't see any particular reports or concerns around diversion that weren't there before. We saw really a small proportion of people who were reporting even knowing someone who had diverted their take-home medications, even when there were more take-homes available. So I think that already shows us, again, this did not become a huge problem during COVID. And I think this also aligns with a lot of the research that was done before the COVID pandemic. There's big fears around diversion of methadone, but it's actually a small minority of people who are even handling diverted methadone. And that's both people who are diverting their own methadone as well as people who are using illicit drugs. It's a very small proportion of people who are actually using illicit methadone. We also know that when people do use unprescribed or illegal illicit methadone, they're using it mostly to treat their own withdrawal symptoms and essentially their untreated opioid use disorder symptoms. So most people are not using it for euphoria. There's plenty of other illicit opioids that are very accessible on the illicit market. And so when people seek to use methadone, it's often just to self-treat because they're, for many reasons, not able to or not willing to use the methadone treatment system the way it's currently structured in the US. So that's something really important for us to understand, because it actually tells us that if people had better access or access to methadone treatment system that was more effective for them and looked like something that they would want to access, actually we would probably see a lot of the illicit diversion go down because there wouldn't be as much demand for it on the illicit market. Two more quick points I want to make is that we do know that regulated and prescribed methadone is safer than diverted methadone, which, right, is kind of an obvious thing to expect. We do see that more overdoses involving methadone, when people have been able to study this, involve non-prescribed methadone compared to prescribed methadone. So what that tells us also is we want people to be seeking methadone in regulated environments. We want people to go to a treatment program to receive methadone rather than buying it on the street, for many reasons that we can imagine why a supply would be safer if you get it from a healthcare provider than if you buy it on the street. The third point is that there are many strategies to reduce diversion risk that do exist and have been tested, and they don't all necessarily involve restricting access or treating people inhumanely, which have many of our strategies to reduce diversion risk have often kind of gone to as a first line standard of care. So just a couple of examples. So as we talked about promoting better access to treatment, there's also a lot we can do in terms of better dosing people. A lot of the research that we know about why people divert their own methadone is because they're receiving too high of a dose and they have extra dose available, while many other people are completely underdosed and they have to buy illicit methadone on the street to get to a dose that will make them feel okay and not sick. And there's a lot of patient education, understanding people's needs that we're not doing that could actually help control a lot of why people are turning to the illicit market around their methadone. And of course, we have other strategies that are well known that can be used with high risk cases, right? We know that there's abuse deterrent formulations like liquid versus tablet form. There's lock boxes, there's callbacks, there's supervised dosing, which we should definitely consider and use these options when appropriate. But the issue is that they've been kind of they've been the standard of care rather than the exception. And we know that these strategies have been really traumatizing to people and are a lot of the reason why people don't want to go to seek treatment, because we're using these as the most important thing about someone's treatment instead of using it as kind of a last resort if there really is an issue around diversion that's being recognized. So I'll stop there and yeah, turn to the others, which I'm curious to hear about others' thoughts as well.
No, definitely appreciate that, Noah. I think one of the things that stood out for me when I was working on one of our policy papers on sort of COVID era lessons was beyond, because I'm a qualitative data nerd. The thing that really stood out to me was the number of providers at OTPs who were talked to, who went into these regulatory changes really skeptical and really worried about diversion, and who kind of came out the other end of it supportive. They were like, wow, I didn't expect to be supportive of this, but I found that so many of my patients did better or were happier. And it doesn't work. It's not for every patient, right? Some patients prefer the system of the structure of an OTP, but certainly a lot really like the freedom that comes with having those take-home doses. And as you mentioned too, like we do have evidence-based options for maybe providing some more supervision or structure for folks who are at a point where maybe that's what they need. I'd love to sort of turn this to Paul as a clinician to talk a little bit, not just about like why methadone diversion happens, right? But thinking about it from that provider perspective in terms of why it happens and what you can, like, what does having that enhanced provider flexibility potentially add to this scenario compared to the way we have it now, where it's very federally regulated?
Yeah, happy to. So, one thing, I'll just say for many years now, working with people who use drugs, people who are addicted to drugs, I'll say something kind of simple, but it's really important just to say is that people who use drugs are just like everyone else, and that they're very practical. They too want to find happiness in life. They want to be safe. They want to have a sense that tomorrow is going to be better than today. And I say that in the sense that as a clinician, as I'm working with people who use drugs, often the things that we're working together to try to help navigate is it's like, how do I fit in my treatment goals with making sure my kid gets dropped off at kindergarten, or I got to wake up early to get to, I finally landed a good construction job. I've been trying to get back into working, in construction. But I'm trying to figure out how to maintain my medication treatment access while trying to do that as well. And I guess kind of like a simple message is that people who use drugs want the same things we are, and that they want to have a chance to be healthier. They want to have a chance to feel free. And unfortunately, particularly with methadone and, a set of heavy regulations that were put in place in the 70s, create a lot of treatment requirements where I, as the clinician or the patient, we don't have a lot of ability to tailor or adjust those treatment requirements. And let me say, like, the schedule for how many take-home doses a person could receive, how often they need to come in for urine drug screens, how often counseling might be a beneficial part of someone's treatment plan. With other chronic diseases, like if I'm helping someone with diabetes, when I send someone to a nutritionist, or when we might decide to change how frequently someone comes in for support, that isn't based on a government regulation when it comes to diabetes. It's based on a conversation where there's trust and reciprocity between the clinician and the patient, and trying to figure out, here's your situation, here's your kind of needs in life. How can we match the treatment plan to what's going to help you be healthy? And because of kind of the historical baggage with methadone as a clinician, and I can tell you, it's very frustrating sometimes when you have to you're trying really hard to meet a person's needs and set them up for the best chance at success. When it comes to methadone, that discretion, that flexibility, that partnership that many of us who work in healthcare, we hope for, it can't happen. And that's very frustrating and difficult, and it ends up hurting people. People end up being hurt by these historically well-intended regulations, but have not been updated and brought up to date with contemporary science.
Yeah, thanks for that. That's really important. And I think, Aaron, would you be open to sharing a little bit of how your personal experience with accessing diverted methadone, like, can you share a little bit about what that looked like? What led you to do that? And how did it impact your life?
Sure, I'm happy to do that. I do want to speak on the topic of personal experience, because I think that, this is something that is often misused, or it's not leveraged the way that it's supposed to be. Because one person will stand up and say, well, this is what I experienced. And then another person will stand up and say, well, yeah, oh yeah, but I had a different experience. And so personal experience shouldn't be the ultimate arbiter of where we go when lives are at stake. When we're looking at thousands of American lives at stake, we should go a little bit deeper than just, hey, Joe had this experience. Now, with that said, science is supposed to start from information from the community. That's supposed to be the first step of conducting science, is to talk to people who are out in the community and are having experiences. And my experience of methadone access has been such that it was not built on that basis. It wasn't built on the type of science that starts from the lived experience of people who use drugs. And it's more informed by cultural attitudes and ideas of people that are separated from people who use drugs, that are in a different class, or that are in a different state of power, position of power. And it's not always intentional. These things are implicit and explicit. But for me, I was just never going to go to a clinic every day. I didn't have the means to do it. And it was a lot about privilege and access as well. A lot of people with the same skin color as me find it easier to go to a clinic every day for a number of reasons. And, despite the fact that there have been drastic racial differences in access across buprenorphine and methadone, these are things that we need to be open and honest about. One thing for sure that I've seen pretty much across the board is that methadone is not a huge recreational substance. And that's what the research shows. There's some of the largest qualitative research on methadone that talked to hundreds of people who use drugs, found that it just wasn't being taken recreationally. And it's a long-acting opioid, right? So when you take it, it takes several hours to peak, which is very different from fentanyl and other drugs that have a very immediate effect. And so that right there is going to create a different dynamic. If you take a substance and it takes several hours to start feeling it, that is going to create a different schedule of reinforcement, which means that you're going to be on a different cycle of behavior, but you're also not going to be in and out of having to use multiple times. With that said, I think a lot of the evidence right now around methadone overdose is coming from pain management, and may have been the result of a lack of education on the long-acting nature of methadone. If somebody takes a drug and they don't feel anything, they say, well, I'm going to take some more. And if it's a long-acting drug, you shouldn't do that. So people need to be educated on the nature of long-acting opioids. And I always was. I knew that when taking methadone, it was an alternative to using 15 times in a day, and instead taking 1 or 2 doses. And that actually, for a lot of folks, prevents the chaos that accompanies chasing an illicit substance every few hours or every day. Whatever your position is about whether drugs should be illegal or not, we can all agree that to use an illegal drug is pretty chaotic. People don't know what the dosage is. They don't know when they're getting it. They don't know what they're getting. And I have seen so many patients as a counselor for whom the way that diversion was dealt with You have these callbacks and daily dosing and observed drug screens. It just disrupted their lives. It prevented access and ultimately has contributed to mortality. Most people who get started on methadone have already taken it at some point. So they know that methadone works for them because they're not going in and out of withdrawal. It lasts long enough to let them go about their business. And they're not engaging with this illicit market that's dangerous to interact with. Now, as I've said, I owe my life to diverted methadone, and I carry the responsibility to speak on behalf of people who could not access it, and many of whom are dead. It's almost like I'm here speaking for the dead and dying. And this is why I call for reason and compassion rather than fear and knee-jerk outrage or even reflexive empathy. We need to think rationally and reasonably about probability. Because at the end of the day, when we have to make a forced decision and many lives are at stake, that's what we have. And COVID has shown us that methadone diversion is not our primary concern, and that the previous system of diversion control of methadone was unwarranted. It was an extraordinary claim to say that we needed to do all of these things to keep methadone from being diverted, and it required extraordinary evidence that was not shown during COVID. Extraordinary claims require extraordinary evidence. And the absence of evidence, where evidence should exist, is also the evidence of absence. So if we don't see something where we would expect to see it otherwise, right? If the previous system was justified, we would have expected to see a lot of overdoses and diversion during COVID. And we just didn't see that. So the absence of evidence is evidence of absence. You're only going to look for so long for crocodiles on the top of Mount Everest, before you give up and say, well, they're probably not there. And extraordinary claims require extraordinary evidence. It was an extraordinary claim to say that people should have to jump through these hoops, that people who use drugs should have to do more than other folks in healthcare. As Paul was saying, we just want the same basic life-saving, common healthcare practices that others have access to. We've shown during COVID that we can do this, even when the stakes are high, even when we don't have all the information. We didn't have all the information with the vaccines, but we acted quickly and we acted decisively, and it saved a lot of people's lives. We need the intellectual humility to know what we know and what we don't, yet still have the courage to act. And I'm really, we're counting on this. Those of us whose lives depend on the decisions of people in power and the decisions of doctors are really counting on people to practice compassion and reason.
Thanks, Aaron. And I think, like bringing this back, right, to the flexibility of providers to work with their patients. And one thing I want to touch on that we'll get to, please folks throw questions in the Q&A and we'll get to most of them at the end. But this one, Aaron, you essentially touched on while you were talking, so I wanted to address it now. Anna Poet, I'm not sure if I'm saying your last name correctly, so apologies if I'm not, asked, do we know why methadone isn't used recreationally? And, it really comes down to, and feel free folks to pipe up, but it really comes down to that slow acting nature, right? So it's not peaking real fast like fentanyl or heroin does, which cause that spike of euphoria. It's coming into your system more slowly. So you hear it described more as just like a gradual arc, whereas most of the illicit opioids that we see are very much of a roller coaster. You get a really fast peak and then that hard drop. But I want to think a little bit about we've got about 15, 20 minutes left for our panelists to speak on this. So I want to get a little bit into what we know about office-based methadone treatment, both in the US and internationally. It hasn't happened a ton in the US, but there's been some pilot studies, and internationally, several countries already do this. So Paul, I wonder if that's something you can talk a little bit about.
Yeah, and sort of, I guess maybe one of the best kept secrets about methadone in the United States is that there's actually, a couple decade history of what's been called medical maintenance. And this goes all the way back to some of the original scientific team that helped discover for the world that methadone could be used to help keep people safe. Vincent Dole and Binswanger. Soon they first discovered that methadone could be used to help keep people safe. But then in the late 70s, early 80s, they started doing sort of another set of experiments where people who were started on methadone, what happens if we transfer their care to an outpatient clinic, a medical clinic, a primary care clinic? The methadone is prescribed and it is dispensed at a pharmacy and using tablet formulations and outside of what we call opioid treatment programs. And they published results, scientific paper. They showed that this change, moving people into office-based settings, prescribing the methadone, having it dispensed in pharmacies, appeared safe. They didn't find evidence of harms. And this medical maintenance model has been repeated. This was in the mid 80s when they first put out this initial research, and multiple other clinical trials have been published on this using different variations. But the basic key here is that patients were transferred outside of the opioid treatment program. They were prescribed methadone and they picked it up at the pharmacy, the same place they might pick up their blood pressure medications. There is some data in the US context, in these medical maintenance studies. They did do some steps to look for evidence of the diversion. So one of the concerns about office-based methadone is diversion. And they took the step, one way of measuring for this is to do what's called medication callbacks. So as a part of these clinical trials of these medical maintenance models, they would randomly call, the patient would receive a prescription, they take the medication home with them from the pharmacy, and a subset of patients would be called at a random day to bring their medications into the clinic. And you count how much medication you have to see if that matches the medication schedule. Trials using this, and then they're also looking for other safety outcomes, overdose, other things. So the trials of medical maintenance did not find evidence of significant harm or risk in terms of diversion, in terms of safety outcomes, in terms of overdose. And, there are multiple studies like this. Unfortunately, it has not been acted on in terms of policy in the United States. Now, so that's kind of the US context. There is this sort of, multiple decade evidence supporting office-based methadone in sort of that medical maintenance model. Internationally, many wealthy countries really went beyond the medical maintenance model in that they allowed methadone to be initiated in office-based settings. So not just transferred from a specialized clinic, but initiated in office-based settings. Countries like Canada, the UK, France, Australia, have for really decades provided a pathway for methadone prescribing and pharmacy dispensing of methadone, including the initiation of treatment in methadone in office-based settings. Each country has a different there are differences in their regulatory approach. They have different requirements in terms of the approach to provider training. The licensing requirements for pharmacies are a little different. But I'll use the example of Australia just to kind of give some perspective on the trajectory. Roughly 2 decades ago, before Australia allowed for methadone prescribing and pharmacy dispensing, methadone was solely dispensed in specialty substance use treatment clinics. They create a regulatory pathway to allow for methadone prescribing, pharmacy dispensing, to address the same issue that we're now facing in the US, just acknowledging that if we're going to make this treatment available everywhere it's needed, this pathway will be necessary. And over time, there was a slow increase in the amount of methadone prescribed in pharmacies. And today, in 2024, now most methadone for opioid use disorder is dispensed in pharmacies in Australia, not specialty clinics. Specialty clinics still play an important role, but most of the methadone is dispensed in pharmacies. Among these wealthy countries, none have reversed themselves after creating a policy that allowed pharmacy dispensing in their countries. So none have had a political or policy situation or data has emerged where they've retracted or since prohibited pharmacy dispensing after trialing it. It's hard to give more, data beyond that because, again, the national contexts are different. The exact policies are a little different. And the things that Noah said, diversion in a narrow sense can be a difficult thing to measure. But at least internationally, no country has reversed pharmacy-based dispensing.
Yeah, I think that's a really compelling point, right? Is that they've gone down this road and not taken the step to reverse it. One of the other things that stands out to me when we try to compare the specific data and risks and overdose factors is that their illicit drug markets are also different, right? So the entire context is often very different. But I would love to hear from you again, Noah, a little bit about the intersection of office-based treatment and diversion. And maybe since you brought it up earlier, some of these alternative ways to maybe provide additional support, even if folks are in office-based treatment with methadone and accessing via a pharmacy. What are some of the things we know about keeping that safe and diversion?
Yeah, so I mean, one thing to add to what Paul said is I think people have the idea that if people are getting their methadone prescribed by a physician and dispensed at a pharmacy, there's going to be no control over methadone. And I don't think anyone's advocating for a system where, a doctor is giving out methadone without any control. Systems that have pharmacy-based dispensing, just like anything else that's dispensed at a pharmacy, have a lot of controls over controlled substances, right? So we currently have methadone in our pharmacies across the US. It's just people can only pick it up at the pharmacy if they have a prescription for pain. The methadone treatment, it's the same exact molecule, it's the same exact medication. So we are already trusting pharmacies to handle those medications safely, to have security around them, in terms of any kind of security risks around interest in accessing those medications. There's a lot of other opioid medications that these pharmacies are already handling and kind of have in place. So I just want to kind of say that as well. And also, how people, there's a lot of different ways in which a prescribing and dispensing in pharmacies system might look like in terms of observed dosing, for example. These are conversations that we have yet to even really been able to get to as a kind of as a country, because there's so much concern about, do we keep everything in the OTPs? Is the OTP the only place that can ever handle methadone? That we haven't even really started thinking about what controls or what processes we can put in a pharmacy-based dispensing system to make sure that people can use safely. So other countries have a different combination of observed dosing. For example, in some places, people have to go to the pharmacy and get supervised dosing in the pharmacies. Other places, you have to do that for, a week. For some places, you have to do that for a month before you get eligible for take home. So the conversation around kind of supervised versus take-home supply does not end at the OTP, and it's not the only place that we can put in those controls. And I think there's a lot to talk about in terms of what the right, what that looks like. But just to say, it's not like we're throwing everything out if we kind of leave the only system in the US to dispense methadone as being the OTPs. And then the second thing I'll just add is in terms of what we know from research. So a lot of what I mentioned in terms of why people use diverted methadone and kind of the risks around diverted methadone, that doesn't come only from US studies. It comes from international literature. And there isn't really any, there's no hard evidence on like a particular system of care or country that has like 100% figured out how to not have any diverted methadone, or a system that has like terrible diversion in methadone. I think there's always going to be some kind of illicit market of anything like this. And so we're seeing similar situations in different countries. And what we see a lot in, for example, qualitative studies with people who are buying illicit methadone, even if it's not in the US, is often because they cannot access methadone. So the US is also not the only country that has, we're probably the most restrictive in how we control methadone, but there's kind of this lack of access is something that we see in other places and is also the biggest driver of people not receiving or trying to find other ways to get methadone from other people. Yeah, so I think, yeah, I just wanted to make those particular points.
Yeah, thank you. I think, you know, it's increasingly clear, right, that at least some of the diversion of methadone for opioid use disorder, it's really a symptom of overly tight regulation and poor access for methadone to treat opioid use disorder. And so before we sort of shift officially over to Q&As, I'd love to hear from each of you. Like, if you had one takeaway for audience members today, for lawmakers, for regulatory folks, pick. What would your one major takeaway be? And Aaron, let's go ahead and start with you on that.
Sure. And, you know, I was raising my hand earlier because there was a question that came up around, you know, recreational value. And when I had mentioned that with regards to methadone, and I just wanted to clarify that the reason why I pointed out the lack of recreational value for methadone is not to make the claim that it's bad to take a substance recreationally. I think that we all kind of accept that this is possible. Folks drink alcohol recreationally. It's a potentially much more dangerous substance. And we accept that that's part of life. The main difference between methadone and other opioids when it comes to the dangers is not the fact that it's used recreationally, but the fact that the quantity and quality is not known. So when a person takes a substance illicitly, they don't know what they're getting and they don't know what the dosage is going to be. And that's always going to be more dangerous than knowing what the dosage and substance actually is. So when we're talking about how available methadone should be, and, you know, balancing this idea of diversion, which is unavoidable, against the potential life-saving value of methadone and the way it's delivered, there's a long list of historical examples that we can draw on of times when we've had to act and innovate in ways that have incurred unintended consequences. And not only is American history, but the history of the world, a long list of major advances that have come along with unintended consequences. So I don't think that anyone here is trying to argue that methadone diversion is not going to happen. What we are saying is that we need to right-size our concerns about it in light of the way we've always dealt with crises like the one that we are facing. And we need to deal with this the same way we deal with other life-saving treatments. You know, when a person undergoes brain or heart surgeries, those are very dangerous procedures that incur a lot of risks. Yet we are fully willing to stomach and incur those risks because of the potential to save someone's life. People who use drugs are no different. People who use drugs deserve the right to life in the same way and deserve the same calculus. Ultimately, this is utilitarianism. It's to say, what is the greatest good, right? And I think we know by now that a simple increase in fentanyl availability is not sufficient to explain the overdoses that we are seeing. There's some other stuff going on. So why would simple methadone access be enough to explain the problems that we might face? And why would addressing diversion be the main thing to talk about? I used the example of the COVID vaccine earlier because I thought it was a good example because the vaccine was developed already before the first person had died of COVID. So we had this tool at our disposal for saving lives. And we wound up saving millions of people's lives because of our agility and willingness to get it out to folks, despite the fact that there were risks of adverse reactions to it. And so we need to apply the same calculus when it comes to people who use drugs, and balancing the risks against the potential benefits. We are poised to lose more Americans than died during COVID before 2030. Okay, that's something that we all need to be acutely aware of. This is what is going to happen unless drastic changes happen. We have a button sitting in front of us with methadone that could cut this number in half or more based on the best available evidence. In order to do this, we're going to have to take drastic measures to the way that methadone is delivered. Drastic times call for drastic measures. And on behalf of people who use drugs in this country, on behalf of the people who have died, I am pleading with you to have the courage to act decisively when it comes to methadone access. You know, courage doesn't necessarily require the absence of fear. We can be worried and afraid about things. It's being willing to be brave even when we're scared, and inferring to the best available evidence and explanations. Our kids and our grandchildren are going to ask us what we did. They're going to ask us what we did to stem the tide and the mass extinction that we're experiencing of our fellow citizens. We want to be able to say that we acted with compassion and reason rather than fear and bias.
Thank you, Aaron. That I think so many good sort of final points in that. And I really appreciate you bringing your perspective, both as an individual and as a caretaker in a methadone space for this. Noah, do you have one takeaway for folks?
I think my takeaway, even just from hearing, you know, so much of what Aaron says resonate, is that I think we don't have to think about reducing methadone diversion and increasing access as mutually exclusive. We could do both at the same time, and we have to think about how to create a more humane system that gets people the treatment that they need, and also reduces risks through building trust, as Paul's been talking about, through improving access and making people feel like they can access a medication that they need officially, instead of having to go to a unregulated supply, which is what is really causing the crisis right now. So that's what I'll end with.
Yeah, thank you. That the lack of regulation and control and transparency, right? It plays, whether we're talking about an illicit substance or a substance that's being obtained through an informal market. Yeah, it's really important. And Paul, if you want to close us out before we jump into questions.
Yeah, and just really quickly, I guess kind of like in some way to really boil this down to a very practical message specifically about the MODA is to just remember that in the United States, Schedule II medications, including methadone, are already available in US pharmacies. What the MODA would enable is to allow methadone for opioid use disorder to be dispensed in US pharmacies. And something that's often overlooked and can just be said very simply, we can, as other countries have already done, dispense methadone for opioid use disorder, prescribed and dispensed in community pharmacies with the same level of oversight of the medication that already exists in opioid treatment programs. As Noah outlined earlier, there are multiple strategies to do this. All of them can be implemented in US pharmacies and have been implemented already internationally. So this, to me, this is one of those, it's a win-win here.
Yeah, thank you. I want to thank all three of you and our audience members for being on today. Whoever has time, we do have a few more questions in the Q&A and have sort of slotted an extra up to half hour for people who have time and are interested to hear a bit more. So I'll start with, we've got one question. Please describe the role of the DEA in controlling methadone. Setting up an OTP, for example, is very complicated. And specifically, if we think about things like jails and the challenge for them to offer methadone, yeah, needing specific safes and video monitoring and things like that. So maybe we can talk a little bit about just the role of the DEA in controlling methadone and getting an OTP set up to begin with, and then how that affects access more broadly. I don't know, Paul, you were nodding. I think Aaron, you might have been nodding as well. So if one of you wants to, maybe Aaron, since your mic is already off, if you want to jump in and give a start.
Yeah, this comes to mind for me because I've been in a few jails advocating for methadone, and I've been involved with several jail-based methadone programs. And at different levels, I've had jails that I've gone to that had never had methadone dispensed in their facility. And then I'd gone to jails that had existing programs that were actually dosing, you know, had their own dosing window and their own ways of dispensing. And it's overly prohibitive. Methadone needs to be dispensed in the same way as any other medication in a jail. There's really no argument for why it should be done differently, because it's such a controlled environment. One of the main arguments that I give when I go into a jail is this is going to make all of our lives easier. It's going to cut down on contraband because people will be bringing in less other substances. It's going to cut down on the risk of overdose because you will know what substance is in your jail and how much of it there is, which is not the current case. It's often the case that many other drugs are much more available in jail, in prison, than they even are in the general public. And drug use is incredibly dangerous in jail because of a lack of safe consumption, safe supplies, and information about how to use without dying. And so methadone helps to mitigate that. It mitigates the liability of people dying while incarcerated. It mitigates the liability of people dying upon release from incarceration, during which a period that people are 40 times, as much as 40 times, more likely to die of an overdose upon release from jail or prison. And so setting up an OTP is very complicated in a jail, as was mentioned in the comment. And this needs to be a lot more accessible to jails and prisons, because as it currently stands, only a small percentage of them allow this. Only a small percentage of drug courts, only a small percentage of criminal justice settings refer, recommend, and coordinate with opioid treatment programs. And this is a tremendous missed opportunity because of the drastic risk of overdose commensurate to the general population for people being released from jails and prisons. And so we do need to look at ways of making incentives, putting incentives in place for jails and prisons to offer methadone and buprenorphine, making it less restrictive to do so, and coordinating ways of doing it that are responsive to the needs of people who use drugs, that encourage participation in these programs and can coordinate treatment access upon release. Now, that's a separate question to the one of how many people should be arrested for drug use, because that is a broader, much more structural issue of how many people should be incarcerated for using drugs, which is something that needs to be addressed. We wouldn't be in this predicament in the first place if we hadn't taken such a punitive approach to drug use over the last century. But we can mitigate much of that by the way we deal with methadone in criminal justice settings. And there are a lot of federal recommendations to this effect. And there are people that have set up OTPs within prisons and jails that have really good examples of how to do this. And we need to take a lesson from them.
Yeah, for sure. I think, when we've tried talking to folks that are operating jails and prisons, it really is a huge barrier. And it is, as you mentioned, Aaron, something that better access in those particular settings could go a long way to save people's lives, especially if there's an effective way to transition on the back end, so that when on release, they still have access to medication. Paul, I know you also looked like you wanted to respond, thinking about the role of the DEA in controlling methadone and specific to setting up an OTP and how that affects access.
Yeah, so very briefly, one thing that's very challenging about methadone treatment and OTPs right now is there are multiple regulatory agencies with sort of a footprint in creating burden on both how OTPs are operated and then also the ability to open new OTPs. So both the DEA, which is primarily focused on the supply of methadone, the distribution of methadone, the safe storage of methadone. Then you have SAMHSA's regulations, which is primarily focused on sort of the clinical and programmatic operations of opioid treatment programs. And then in addition to that, you have the state opioid treatment authorities, which add on additional regulations onto opioid treatment programs. All of these regulations have the effect of both limiting the sort of ability of these programs to innovate. It's also, for decades, people have been calling for open up more OTPs, but these regulations and also the community resistance to opening new OTPs has proven to make it very difficult. And we've not been able to open OTPs to meet the significant unmet treatment need.
So our next question asks, it's kind of a huge question in terms of Right, recognizing first of all, we know methadone is the gold standard for opioid use disorder. I do think it's noteworthy to say this is especially true with fentanyl. It seems to have fewer complications in terms of induction than buprenorphine does. Obviously, right, so the question asker notes restrictions and stigma within treatment make it really difficult to access methadone. Obviously, there are multiple approaches needed to expand access and destigmatize treatment. So what's next to make sure that we can improve treatment access and get this life-saving medication to the people who need it most? And then the kind of big one, how close are we to being able to get methadone at a pharmacy daily instead of having to go specifically to an OTP? Does anyone want to take a gander at that? I mean, no, go for it, Paul.
I could just quickly say that this is one of the reasons why passing MODA, I would say, is so important. You know, I'm a clinician, but I'm also a health services researcher, and part of the science that I focus on is called implementation science. And that's sort of the science of you take a new program, a new approach to solving a problem, and how do you implement it? How do you bring it to, you know, the population, bring it out into the real world? You know, many of us in the addiction, you know, treatment space, we are very concerned and we recognize the need to make methadone more accessible. But in some ways, you know, a scientist like myself, I can't innovate. I can't propose new programs when something remains illegal. And so there'll be a lot of practical work about payment models and pharmacist training, clinician training, and these things. But in some ways, we can't get off the starting line while the prohibition remains in place. And I think that's kind of the key message that I would have on that.
Yeah. If I could just add, I think actually Paul and I were on a call earlier and talking about this a little bit, but I think what would make a big difference in helping MODA or something similar eventually pass is actually getting OTPs on board with the idea that expanding methadone to pharmacies will benefit everyone, especially their patients, but also just, you know, our communities, and the OTPs have to be part of this as well. The OTPs will be an important part, even in a pharmacy-based dispensing system, including prescribing happening at OTPs, maybe some dispensing happening at OTPs, a lot of other services that people do benefit from happening at OTPs. You know, the idea is not to move methadone out of OTPs and get rid of them. So, you know, my question, I guess, or kind of ask of the audience or people who are watching this today is, you know, how can we kind of address some of the concern, you know, important concerns about diversion, risks around methadone, but also, you know, really talk about making it expanded access. We know the current system isn't working. We know not enough people are accessing OTPs. So yeah, I just kind of welcome, you know, people from a lot of different perspectives on this, to work together towards making methadone accessible through pharmacies as one place, among others, where people can get this treatment, and really think about, you know, I think everybody's on the same page. Everyone wants to get people access to this treatment. People want diversion to not be something very frequent. We want to, you know, make sure people are taking medication safely, and it's these types of conversations that can help us have that, but we have to be working together and not kind of in contrast in terms of what the goals of a humane methadone treatment system can look like.
Yeah, thank you.
I'll just quickly say, because I thought Noah brought a really good point up. In Canada, where they've had office-based methadone for a long time, most methadone prescribing still comes from specialized treatment centers that is the rough analogous, you know, the rough analog of opioid treatment programs. In other words, if we have methadone prescribing and pharmacy dispensing in the US, OTPs are likely going to be a critical part, a central hub in that system. And so in other countries, it's not like specialized treatment centers disappeared with pharmacy dispensing. So I think that's a really important message to get out.
Yeah, for sure. Aaron, did you want to chime in on that? sort of thoughts around what we need to make sure we improve access and really get it. I think you've brought up a lot of really interesting points, right? That often it's the folks who are most marginalized in this society who already struggle the most to access treatment. And how do we get this medication to the people who need it most?
Yeah, and on the topic of pharmacies, it's a simple numbers game. We could scale up to the point of making methadone available to a great number of people by delivering it in pharmacies. It's one of the biggest technological advances that I think we could leverage. It needs to be done in a way that's not stigmatizing, but there will always be, for a long time, there will be stigma against people who use drugs in healthcare settings. And this also applies to opioid treatment programs. And that's part of the reason why I brought up incarcerating people for drug use, because all cultures across the world criminalize and make things illegal that they wish to stigmatize. The purpose of making something illegal is to stigmatize and discourage it. And so that's been done with drug use. And there's no way that that's not going to affect healthcare. There's no way that that's not going to affect the delivery of treatment. And there's no way that's not going to affect the attitudes of anybody who's interacting in a healthcare setting with people who use drugs. And when we talk about methadone delivery in a pharmacy, we have to acknowledge that. We have to acknowledge that people who use drugs avoid general health care for very good reasons. And many of us won't go to the doctor until we're almost on death's door because of the experiences that we've had, the differential treatment that exists that we can rely upon. And this is something that needs to change if we want to see actual advances in our ability to save lives and our ability to reinvigorate the workforce and our ability to address this massive drain on our culture and economy. And so methadone delivery in pharmacies would be a great way of doing that. It's a win-win for the opioid treatment programs. I think it's an opportunity to cut a lot of the costs that are associated with having to open a clinic every time you want to dispense methadone. There have been advances with telehealth that are already in place. That the Substance Abuse Mental Health Services Administration is now allowing, that could significantly allow access beyond what it has been historically. And what this does is it changes the culture among people who use drugs with regards to methadone, because there's stigma against methadone among cultures of people who use drugs. And most of that has to do with what a person has to do to be on it. And once a person has reached the state of compliance in a methadone treatment program, they've had to really separate and distance themselves from their drug using identity to the point of really creating this barrier. And so there is a hierarchy, there's tribalism, and there's a lot of animosity between communities of people who use drugs that methadone contributes to. You have the compliant patients and the non-compliant patients. And that's why I started this podcast, because I'm trying to tell the story of the non-compliant patient that doesn't get told. But methadone in pharmacies is an opportunity. I think folks need to start thinking of it that way. It's not a threat to anything. It's actually an opportunity to expand this in a lot of the ways that many folks have been dreaming about and trying to do within the existing structure and been unable to do. And once we begin to see the results is when the changes will happen. Stigma will start to go away once healthcare providers become accustomed to working with people who use drugs. And we're never going to get to that point by waiting around for all of them to be ready. We're going to have to just do this and build it, and they will come. And that's what I believe.
Yeah, and I think, that's a really great point, Aaron, because it is something that we see both with the qualitative research during COVID on a lot of this, right? We've seen it with studies for this, for the methadone medical maintenance, right? Where once providers kind of start doing this, when pharmacists start actually maybe engaging in supervised dispensing, or when they start dispensing and they haven't in the past, a lot of their fears around what it means to provide methadone to a patient start to go away. They realize, oh, these are people who are coming to me for medical care in line with any other medical care that I might provide. And so I do think there's really a lot to say, and that's one of the advantages of potentially incremental change and making one person in our questions has noted they checked specialty providers, right, in their area, and which is what MODA would provide prescribing privileges to. And they found that there still are not any specialists within 40 miles of where they live. So then what are their options in this situation? And that does start to get tricky, right? Because is it enough to really provide full access? But with where we're at, I think what it does represent is a step to start to really reduce a lot of the stigma, and for people to realize that it is possible to help folks manage methadone from an office-based setting. There are ways to make sure, I think Noah, you said, right, preventing and taking care against diversion and expanding access are not mutually exclusive. These are things that work together. And if we've learned anything from the data and from this talk today, it's that expanded access is actually likely, especially in the long run, to start reducing that diversion because there's less need for diverted methadone, right? I've got a question here on how did the US get trapped in the current opioid treatment programs in the 1970s, particularly given the findings Paul Jodrey described of studies of medical settings providing methadone? Does anyone want to speak to sort of how we got stuck in this system that doesn't really allow for very much or do we think that it's really about, what we've been talking about, the stigma and the sort of punitive approach to all of this?
I can just jump. So I think it's all of those things, and we can talk about a lot of factors that have kept the system the way it is. I think one thing that happened is that buprenorphine came out in 2001, and became available as an office-based prescribed treatment for opioid use disorder. So after the 90s, where a lot of people were still having conversations about how to improve the methadone treatment system, suddenly there was an alternative that worked for a long time. The reason we're coming back to a lot of these conversations around methadone is because in the new era of fentanyl, like you mentioned, Stacey, we're seeing that buprenorphine is just not working as well as it did. For some people, it never really worked, and there was people who have been fighting to change the methadone system for a very long time that maybe haven't gotten kind of as much of a national platform as there is about this topic now. But there was an alternative that at least was kind of playing this possible role of an alternative to methadone. And now we're seeing that it's just not enough. And the situation has just gotten so much more dire. And yet we're still working with this system that existed even pre-buprenorphine. So I'll just say that as one really kind of important reason and why it's so critical that we're talking about this now. I think many of us wish that the system had changed a while back, but it's just more important than ever. And there's a lot of momentum around, like you mentioned, the natural experiment that we, unfortunately had to experience during COVID, to see that there is another way to deliver methadone. And it doesn't have to be this really restrictive, punitive system that's really built on fear, and this idea of fear to get people access to this treatment that is like so direly needed more than ever.
Yeah.
Yeah, I think you kind of have to put things into context. Rewinding the clock to the 1970s, I interviewed a patient who's been on methadone for 40 years last week for the podcast. And this is a person who has been compliant, and which is not an easy task. Depending on the clinic, you may have to be an absolute saint to be a compliant methadone patient. But even after that many years, is still unable to travel and lacks a significant amount of freedom in her life, going into retirement, to really enjoy retirement because of the need to be tethered to the clinic. And hearing her speak about what things were like during the 1970s and 80s toward people who use drugs, it makes a lot of sense that the current methadone treatment regulatory system that exists, that hasn't really been updated since then until recently, would be put into place because of public sentiment and because of general cultural attitudes about drugs and the people who use them. And what I see now is a significant shift in the zeitgeist because people are starting to recognize that what was done didn't work. We can't, and I'm hearing law enforcement folks say we can't arrest our way out of this problem. I'm hearing government entities mention the phrase harm reduction, which I owe my life to. And I think that methadone is a form of harm reduction for many folks, which is that it's a safer option. Even if they continue to use illicitly, it reduces the desperation of their use, makes their use less dangerous. And that is success. And so in the 1970s, we just didn't see that. We weren't ready to adopt and accept that. We were still grappling with gay marriage and, a lot of other social rights issues. And yet, with that said, the revolution that's happening with methadone reform right now that I'm part of is drawing on those movements. And the time is now. We are seeing the cracks and the changes in the system that are happening and hoping that the arc of history will lean in the direction of justice when it comes to methadone.
Yeah, so I think it's super interesting, right? If we think about this with more than 50 years of history, but then also in the context of buprenorphine and those changes more recently in terms of the limitations on getting us out of this. So we are just about out of time. I wonder, so the whole 40-mile radius question, right? Someone noted that MOTA would not give them access within 40 miles. What is a person to do then who wants to be on methadone? And even if we expanded prescribing, right? And I think, Paul, your study found that like the number of census tracts that would be covered under MOTA would expand from like just under 50% of US Census tracts to almost 2/3 of US Census tracts. So it's a substantial improvement. It's particularly a substantial improvement for folks in rural areas. But as we see here, that there would still be barriers. So what sort of, as we close out, what are the options remaining to folks who are still more than 40 miles away from a provider?
Yeah, exactly. So we did a study that just looked at where methadone would be available under current conditions if the MOTA passed, and then if we created a regulatory pathway for primary care clinics to offer methadone prescribing for opioid use disorder. And just as you just quickly summarized, MOTA passage would have a clear and marked expansion in methadone availability. And what's important to note is that places where the OTPs tend to not be available in suburban and particularly rural communities. And so rural communities stand to benefit in the simple sense that methadone would become available where there really isn't a treatment option. However, what I'll just note is most other wealthy nations that we've talked about earlier have created a pathway for primary care providers to be able to prescribe methadone. They may require some additional certification or training to do it. But what our study seems to suggest is that if we really want to ensure all rural communities have access to this treatment option, our data suggests that moving forward beyond the MOTA, it is likely that some sort of comparable approach where primary care prescribing becomes an option is likely needed to ensure this treatment's available in all communities where people may need it.
Yeah, and I think, what we might be seeing here is this is potentially a really good opportunity to reduce some of the stigma, see that, the sky doesn't fall when office-based prescribing is an option. And allow for a system to get in place, right? That helps sort of provide the additional structure that might actually be beneficial and help mitigate diversion risks and other concerns like that. You know, our last comment was sort of a recognition that it sounds the potential of doing some of these programs sounds a little bit like the hub and spoke models that have been present for buprenorphine over the years, and then allowing them for methadone. And I think, you know, what we've seen with buprenorphine is we did see a gradual policy change that started to expand access over the last 24 years. And so I think what we saw with that was that we could expand access and it saved a lot of lives. And the hope is that with incremental change to improve access for methadone, we'll see a lot of lives saved, and lives improved as well at the same time. So we are running up on our time. I am so thankful to all three of you for your time today and for your wisdom and insights and thoughtful conversation. And for our audience members who stuck around for, I mean, this turned into an hour-and-a-half panel. So really grateful for you all. I don't know if anyone wants any closing comments, wants to send us off. That's great. But otherwise, just thank you so much.
Thank you. And thanks for leading this important session.
Yeah, thanks so much for the opportunity to talk on this topic. It's been great.
Yeah, this was great. Thank you, all of you, for organizing, and it's been great to chat.